Welcome to the debate. Today we're diving into a really fascinating and incredibly complex area of rheumatology, rheumatoid arthritis, or RA, overlap syndromes. So we're not talking about the, pure or straightforward cases of RA today. Instead, we're exploring situations where patients diagnosed with RA also show significant clinical features or specific blood test markers, serological features, or even changes in tissues, pathological features that really look like other distinct connective tissue diseases. We often call these CTDs. Think conditions like systemic lupus erythematosus, SLE, or systemic sclerosis, scleroderma, maybe polymyositis, or mixed connective tissue disease, MCTD, things like that. And the central question guiding our discussion is this. When a patient has RA alongside features of another CTD, is this mainly a complex, let's say, variant of classic rheumatoid arthritis, where RA is still kind of the main diagnosis? Or does the striking presence of these distinct overlap features mean we need to think about it as a truly separate, complex clinical entity, one that demands a fundamentally different understanding and, importantly, a different management approach? My position today is that RA really does remain the foundational diagnosis here. These overlapping features, well, they modify its presentation, sure, making it a more intricate version of essentially the same underlying disease.
And I'm coming at this from a distinctly different angle. My contention is that the unique and, frankly, often profound features of these overlapping conditions, especially their tendency for, widespread organ involvement, are just so significant that they really elevate these presentations beyond simply being RA variants. I believe they establish these as distinct clinical entities that truly warrant their own classification and, critically, their own conceptualization, both in how we research them and how we care for patients. It feels like a shift from just adding layers onto RA to really recognizing a fundamentally new disease landscape.
Okay, so my core argument for viewing RA overlap syndromes as, let's call them complex presentations or variants of RA, it really centers on the fact that the RA component consistently remains central to both the diagnosis and, crucially, the initial therapeutic strategy. We see this time and again in how patients present. They show up with classical RA features, the symmetric polyarthritis, inflammation in multiple joints, both sides of the body, that characteristic morning stiffness that can last for hours, the telltale joint erosions you can see on x-rays, and very often they have positive rheumatoid factor, RF, or anti-CCP antibodies, which are pretty specific blood markers for RA. These aren't just minor things. These are the core diagnostic hallmarks that clinicians identify first and, rely upon. And furthermore, look at the treatment. The base treatment approach for these conditions reliably starts with disease-modifying anti-rheumatic drugs, DMARDs, like methotrexate, leflunomide, sulfasalazine, hydroxychloroquine. These are the absolute cornerstones of RA management. Even when we have to escalate treatment to more advanced biologics, things like anti-TNF therapies, rituximab, Abicept, or tocilizumab, all prominent agents in RA treatment, their selection is often influenced by specific organ involvement. Yes, I grant that. But it doesn't really represent a complete abandonment of the RA treatment paradigm. It feels more like selecting the RA biologic that's best suited for the accompanying systemic issues. In fact, what some research even suggests is that joint damage might actually be less severe in certain overlaps, like Rupus syndrome, that's the RA-SLE overlap, compared to classic RA. Now that suggests that the presence of the other CTD isn't overshadowing RA, but maybe modulating the RA phenotype itself within a complex interplay, not some entirely different disease process kicking in.
I find that interpretation a little difficult to fully accept, though, especially when we consider the sheer scope of these conditions. My core argument really hinges on the fact that the unique clinical features, the very specific serological markers we find, the significant and, let's be honest, often life-threatening organ involvement, and the specialized treatments required for these overlap conditions, all of this means they simply must be regarded as distinct clinical entities. The necessity for specific, you could call it overlap-specific management, that deviates profoundly from standard RA protocols, that provides compelling evidence right there. For instance, think about the absolute requirement for potent immunosuppressants like cyclophosphamide, or maybe antifibrotic agents like nintedanib, which targets lung scarring for patients with scleroderma and interstitial lung disease, ILD, a really serious lung condition, or needing belimumab for certain cases of lupus overlap, or maybe azathioprine or mycophenolate for myositis, which causes muscle inflammation. These aren't just, minor tweaks to an RA regimen. These interventions are crucial, often life-saving, and they specifically target pathologies that are distinct from RA itself. And the implications go beyond just treatment choice. The prognosis of these overlap syndromes is incredibly variable, and it often involves more extensive systemic involvement. Mortality is frequently linked directly to specific organ complications like lung fibrosis or severe renal disease, kidney failure. Now, that fundamentally alters the disease trajectory compared to typical pure RA, where mortality is more often driven by the joint damage or maybe cardiovascular complications related to chronic inflammation. This is a dramatic shift in how we counsel patients and how we prioritize their care. Moreover, the presence of these highly specific autoantibodies, these self-attacking antibodies in the blood, like anti-dsDNA and anti-SM for SLE, or anti-SCL70 and anti-centromere for scleroderma, anti-Jo1 for polymyositis, and anti-U1RNP for MCDD, all of these point to fundamentally distinct immunological pathways and pathologies far beyond what we typically see in just RA. Our diagnostic workup also expands dramatically. We move beyond just looking at RA markers to specific organ assessments, high-resolution CT scans of the chest, HRCT for ILD and scleroderma overlap, checking muscle enzymes and doing electromyography, EMG for myositis overlap, detailed kidney function tests and urinalysis if we suspect lupus nephritis, kidney inflammation from lupus. This multisystemic nature, it just clearly demands a distinct conceptualization, doesn't it?
Okay, while I appreciate that perspective on treatment, I think I see it unfolding somewhat differently in practice. The consistent initiation with those, let's call them traditional DMARDs, as the base treatment really does strongly indicate that the inflammatory arthritis component remains fundamentally RA. Now, I absolutely acknowledge the need for those specialized treatments for organ involvement, and yes, they are critical. But I'd argue these are essentially targeted additions to address complications. Rather than a complete replacement of the core RA management strategy, we wouldn't, for example, just abandon methotrexate for a patient's arthritis simply because they develop a particular skin rash or some other systemic feature, would we? I mean, the foundational inflammatory arthritis still drives a significant part of the patient's suffering and requires that baseline RA-centric management.
I have to respectfully push back on that assertion, and here's why. While DMARDs are indeed a common starting point, yes, for the joint component, the absolute necessity for agents like cyclophosphamide, a really powerful immune suppressor, or belimumab, a biologic specifically designed for lupus, to manage life-threatening organ involvement from the overlap conditions, that demonstrates these are not mere adjuncts. These specific therapies address distinct pathologies that are defining features of a new, complex entity, not just complicated RA. You simply cannot treat severe lupus nephritis, serious kidney inflammation, or progressive lung fibrosis, which is irreversible scarring, with methotrexate alone. The treatment paradigm doesn't just get added to, it fundamentally shifts to accommodate the dominant life-threatening features of the overlap. Often we're prioritizing interventions that have little or sometimes no role in pure RA.
It's a strong point you raise about that paradigm shift. But I'd frame its significance perhaps in another light. Even in, classic RA, management often adjusts for extra-articular manifestations, issues outside the joints. We might strategically choose biologics that are known to have some effect on RA-related interstitial lung disease or vasculitis, blood vessel inflammation, all within the broader RA spectrum. The systemic features in these overlap syndromes are certainly more pronounced, maybe more severe, I'll grant you that. But the overarching framework of managing inflammatory arthritis still seems to point to RA as the central entity. These additional, albeit significant, considerations are layered on top. It feels like a highly customized RA treatment plan, rather than an entirely new recipe, you see.
I concede the strength of your point on RA having its own extra-articular manifestations. That's true. However, when we factor in the ultimate prognosis
and especially the primary cause of mortality and overlap syndromes, which are so frequently tied to these specific organ involvements, like lung fibrosis or renal disease, doesn't that fundamentally redefine the core identity of the condition? This shift in the most critical aspect of a patient's disease trajectory, moving maybe from the primary concern of joint destruction and cardiovascular risk in pure RA to potentially life-threatening systemic organ damage, that strongly argues for recognizing a distinct disease entity that demands its own classification. The focus of care, the critical monitoring, the patient's very survival often pivots entirely to these non-RA driven complications, and this has profound implications for how we communicate with patients and how we organize, say, multidisciplinary care. Now, moving on to how we interpret serological markers and diagnostic criteria, I find myself looking at that data from, well, a slightly different angle. The presence of highly specific autoantibodies like anti-dsDNA or anti-SCL70 antibodies that are considered pathognomonic, meaning uniquely diagnostic for other CTDs, they can't just be subsumed under an RA diagnosis, can they? They signify fundamentally different and distinct immunological processes that define separate conditions. That compels us, I think, to view these as distinct entities. These aren't just generic markers of inflammation. They are precise indicators of specific autoimmune pathways, often dictating the very type of organ involvement we anticipate and guiding our whole diagnostic pursuit.
I'm not entirely convinced by that, especially when we consider the full clinical picture. While these specific autoantibodies are certainly indicative of other CTDs, it's crucial to remember that patients in these overlap syndromes still consistently meet the established diagnostic criteria for RA, often with those positive RF and/or anti-CCP antibodies we talked about. This suggests, to me at least, a complex immunological confluence, a kind of intricate intertwining of pathogenic pathways, rather than a complete replacement of the RA diagnosis. The very term overlap implies this shared territory, right? This merging, not necessarily entirely separate diseases that just happen to coexist randomly. It suggests a broader autoimmune dysregulation where RA remains the primary clinical manifestation, albeit one complicated by additional features.
My view on that differs significantly, and I'd argue this point leads us to a really crucial conceptual distinction. If a distinct immunological profile, like anti-U1RNP positivity, is used to define mixed connective tissue disease, MCTD, as its own entity, a recognized condition with features of SLE, scleroderma, and polymyositis, then why should an RA patient who presents with, say, anti-dsDNA and then develops nephritis, kidney inflammation, be considered merely RA with lupus features rather than a conceptually distinct lupus syndrome? The specificity of these autoantibodies and the multisystemic clinical picture they often herald, it frequently dictates an entirely different diagnostic and management algorithm. That makes it conceptually distinct, certainly in the minds of clinicians actually treating these patients day to day.
That's a powerful way to put it. And it really does highlight the challenges in classification. However, I'd invite us to consider how even the term Rufus syndrome itself specifically incorporates rheum from rheumatoid. This nomenclature, which has gained clinical acceptance, it seems to acknowledge the profound lupus features while still retaining the RA component as foundational. It doesn't present it as an entirely new disease category, does it? Rather, it suggests a recognized subphenotype, a complex variant of RA with significant modifying features. The very naming convention seems to imply a primary anchor to RA, emphasizing its continued presence and influence within the broader presentation. Okay, moving to our final point then, about prognosis, organ involvement, and disease identity. I find myself looking at the research data and reflecting on what it illuminates.
The material notes, as we mentioned, that joint damage may be less severe in some overlaps, such as lupus, compared to classic RA. Now, this indicates that the RA component itself is being modified or attenuated within the overlap. That suggests a variant of RA rather than a completely different disease emerging to overshadow it. If the core RA pathology, its destructive potential, is somehow tempered by the presence of another CTD, it implies an ongoing interplay within the RA framework, rather than an entirely new disease just taking center stage.
I find that interpretation difficult to fully accept, frankly, because it focuses on a potentially less severe outcome in one specific area, while perhaps overlooking the profound implications elsewhere. While articular damage might indeed be attenuated in some instances, and that's interesting, that feels like a relatively minor consolation when we consider the overall variable prognosis and the more systemic involvement. Mortality, as we've said, is often directly linked to specific organ pathologies like life-threatening lung fibrosis or severe renal disease. This shift in the primary threat to life, moving from joint destruction and its consequences to potentially fatal vital organ failure, fundamentally redefines the most serious aspects of the patient's condition. It points, I believe, to a distinct multisystemic disease entity where the overlap features are paramount, often eclipsing the RA component as the main clinical concern and the driver of outcome.
You've highlighted an important detail there about the shift in primary threats. That's fair. But I'd frame this differently again by recalling that RA itself can have severe extra-articular manifestations. Interstitial lung disease or vasculitis associated with RA can certainly be life-threatening. The overlap, in my view, might simply represent a heightened, perhaps more specific manifestation of that systemic inflammation originating from an RA base. It could be seen as an exacerbation or a particular direction of the systemic inflammatory potential that already exists within RA itself, rather than an entirely novel disease process taking over. It's like the same inflammatory fire, just spreading in a more complex, maybe more dangerous pattern.
That's a compelling argument, connecting overlap features back to RA's own systemic potential. I see the logic. Yet I'd invite us to consider how the absolute necessity for specific organ assessment investigations, like that chest HRCT for ILD and scleroderma overlap, or the detailed renal function tests and urinalysis for lupus nephritis, fundamentally alters our diagnostic approach. These are not routine RA follow-ups, are they? They are driven entirely by the distinct, potentially life-threatening features of the overlapping CTD. That, to me, solidifies the argument for a separate classification or conceptualization. Our clinical protocols, the urgency of intervention, they pivot to these specific non-RA threats rather than just, say, escalating standard RA management.
Okay, as we conclude our debate then, my position remains that RA overlap syndromes, though undeniably complex and requiring incredibly meticulous, individualized care, are probably best conceptualized as sophisticated presentations or variants of rheumatoid arthritis. The RA component, I believe, provides the core understanding and the baseline treatment strategy. The other connective tissue disease features, well, they add critical layers of complexity that necessitate tailored adjustments, certainly, but not a complete abandonment of the RA conceptual framework. The continuity of those core RA features and the established treatments seems to anchor it firmly within the RA spectrum, demanding a nuanced, yet fundamentally RA-centric approach.
And I continue to argue that the distinct serological profiles, the often severe and life-threatening organ involvement, and the absolute imperative for specific, often non-RA therapies in these overlap syndromes fundamentally distinguish them from classic rheumatoid arthritis. These features, I feel, compel us to consider them as distinct clinical entities that necessitate their own conceptualization and management paradigms. We have to acknowledge that the patient's primary challenges, and indeed their prognosis, often stem directly from the overlapping condition, sometimes even dictating therapies that would be completely irrelevant in pure RA.
Our discussion today really does, I think, illuminate the intricate nature of autoimmune disease and the profound challenges in classification that clinicians face every day. While there remains clearly a substantive disagreement on whether these represent complex variants of a primary RA diagnosis or truly distinct clinical entities, both our perspectives converge powerfully on the critical need for a comprehensive diagnostic approach and highly individualized management plans for every patient with an RA overlap syndrome.
Indeed. And this exploration underscores the immense value of considering multiple perspectives, doesn't it? It helps deepen our understanding of these truly challenging conditions. It highlights that medical classification is rarely a simple, clear-cut endeavor, and it suggests there is always more to explore in the nuances of disease identity, and ultimately finding the optimal patient care in these incredibly complex presentations.